Today we'll speak about tuberculosis. In spite of progress in methodology of investigations and treatment in tuberculosis, still a number of deaths are occurring annually, particularly in India. That too, with the addition of AIDS, this incidence is increasing day by day. Some tuberculosis controls are being conducted. Domestic treatment is being done, but in spite of that, tuberculosis is, its incidence is increasing. So let us talk about tuberculosis and radiological diagnosis of tuberculosis from head to toe. This is a systemic disorder, so no organ is exempt from tuberculosis. However, certain organs, particularly the lungs, are prominently involved. We will go through the head, chest, spine, limbs, genitourinary tract, GI tract, etc. For example, take the skull. Tuberculosis of the skull bones is not common, but however, we'll see once in a while. And then how do you identify from pyogenic osteomyelitis? You have to differentiate whether it is tuberculosis or not. If there is a small sinus tract with serosanguinous material, clinically they can make a diagnosis of tuberculosis of the skull bone. The major finding or the major differentiation between pyogenic osteomyelitis and tuberculous osteomyelitis is, one, in pyogenic osteomyelitis, there is pronounced sclerosis of the bones, reactive sclerosis. Whereas here, there is osteoporosis, there is no sclerosis at all. Sequestra may be common in pyogenic osteomyelitis, not here. Fungal osteomyelitis, it is a slow process, so there is a lot of sclerosis there, a lot of thickening of the calvarium, a lot of bone reaction. The one on your left side, you see the tuberculosis of the skull with multiple lytic areas, and the frontal and parietal bones are very common. Whether it is hematogenous infection or from the sinuses, whatever the reason may be, but the lytic areas are characteristic of tuberculous osteomyelitis. One on your right side, particularly in a child, in an infant, cystic tuberculosis is common. There are several reasons why cystic type of tuberculosis occurs, but in this particular case, you can see multiple lytic areas. The only disturbing feature is there is a lot of reactive sclerosis surrounding it. So occasionally, multiple pyogenic osteomyelitis foci can be seen in skull, but this proved to be tuberculosis. Now we come from skull to the meninges. Tuberculous meningitis is also common. It's not as rare as tuberculosis of the calvarial bones. Diffusely enhancing, uniformly thickened pachymeninges. So look at those arrows. Thick meninges and exudates we can see. And these exudates, particularly in the basal cisterna, produce hydrocephalus. Cranial tuberculosis meningitis. Apart from spinal tuberculosis meningitis, abnormal meningeal enhancement in the basal cisterns, as I said earlier. The abnormal enhancement of the choroid pleasures also. And what are the complications? Hydrocephalus, because of the exudates obstruct the CSF flow, and vasculitis resulting in small infarcts. Here, an example of tuberculous vasculitis with multiple small infarcts. This is a 2-year-old boy with history of perinatal asphyxia, presents with cerebral palsy and delayed milestones. As you see, the right basal ganglia and high parietal region reveals hyperintensities with complete cutoff of middle cerebral artery. Look at the arrow. So there is vasculitis and thrombosis producing infarcts. Now tuberculoma. It is a little different from tuberculous meningitis. Tuberculoma occurs in the brain, parenchyma, area of solid caseous necrosis surrounded by collagenous capsule. Resembles a tumor, that's why it is called tuberculoma, space-occupying lesion. And on CT, iso or hyperdense lesion with mass effect and control central calcifications. 29% of the time you can detect calcifications. Whereas if you take plain films of the skull, in olden days, we used to see calcified tuberculomata. But today, calcified tuberculomata, seeing on the plain film, is rather rare. It can occur. It may be silent and then it may calcify. Same thing in tuberculous meningitis also. Occasionally you can find calcific plaques of meninges, indicative of meningitis, healed type of meningitis. And then there is one target sign in tuberculoma. What is that? Isodense lesion with central calcification showing peripheral rim enhancement. That is the target sign. But how does MR help? Well, it is in a T1, it is hypointense, and T2 also it is hypointense. That's how you differentiate from cysticercosis. Homogeneous, nodular, thick, irregular peripheral enhancement is there. Here is an example of periventricular tuberculomata. Look at the conglomerated ring enhancing lesions. They used to call it Olympic type of rings. And then in basal cisterns, you could see. In occipital lobe, well defined, almost a ring-like lesion or double rings, enhancing lesions in occipital lobe. This enhances with contrast. Central area, note, it is hypodense. Thalamus, this for example, this patient is a 20-year-old female detected to have HIV positive, presented with seizures. That is the common presentation. In T1 weighted images, you could see altered signal intensity in the thalamus with pre-lesional or peri-lesional edema. Same thing you could see in T2 and also in the next one. Another case of tuberculoma in the thalamic area. This is a 20-year-old female known to have HIV positive. She presented with seizures. And as you see in T1 weighted image and T2 weighted images, altered signal intensity in the thalamus, you could see that, and peripheral enhancement of the edema. In the parietal lobe, another case, 8-month-old male child with history of deloid milestones and right hemiparesis. Nodular ring enhancing lesion in parietal lobe, you could see one on your right side, also in the left side. It is best seen in the T2 weighted image with a ring enhancement. And note also the obstructive hydrocephalus as a complication. Multiple, they can be multiple. Sometimes they simulate cysticercosis. Multiple CNS tuberculosis, conglomerate ring enhancing lesions with perilesional edema. In AIDS patient, tuberculoma, multiple tuberculoma is common in AIDS patient because it is extensive involvement. And then we come to tubercular abscess. How is it different from tuberculoma? All right, it simulates a pyogenic abscess with a thick rim. This, for example, 20-year-old male presented with history of seizures again. Central necrosis is replaced by semi-solid pus pathologically. That's why they call it tubercular abscess. Of course, the treatment is the same, but occasionally it may not respond for the treatment. It has to be drained, like pyogenic abscess. Granuloma, 27-year-old female presented with right hemiparesis, but then several times we find difficulty, is it a glioma, is it a tumor, or is it a tuberculoma? And there spectroscopy helps. MR spectroscopy showed elevated lipid peak and normal chlorine and sodium ratio. And then you could see contrast enhanced MRI showing ring enhancing lesion in the left thalamus. This is how MR spectroscopy helps in differentiating from granuloma and a tumor. Now we come down from skull to the meninges and to the brain, and then now we come to the spine, cervical spine. When you look at the entire axial skeleton and compare with peripheral bones, About 60 to 70% of the tuberculous lesions occur in the axial skeleton. Of course, in the thoracolumbar area more frequently, but occasionally you can see in the cervical spine also. Wherever it occurs, the major classical findings on plain film is the narrowing of the disc space, erosion on either side, and a paravertebral abscess. And here, of course, in MRI of the cervical spine, you will notice a retropharyngeal abscess or prevertebral abscess, huge abscess causing dysphagia. And now disseminated tuberculosis, although we said it is a systemic disorder, but always it doesn't express in multiple organs. Only sometimes it expresses in multiple organs, but most of the time it is focused. For example, pulmonary tuberculosis. You may not find any skeletal tuberculosis or genitourinary tuberculosis or even GI tuberculosis. But then since it is a systemic disorder, you have to look for other foci. Disseminated tuberculosis, in this case, involving liver, you could see. Spleen, notice those attenuated, low dense areas. Weight, the patient presented with weight loss and loss of appetite. And contrast enhancement of CT of abdomen, you can see all the lesions. Endobronchial TB. It simulates miliary TB, but these are nodular, multiple nodular type of densities you could see on the CT, well expressed. The CT appearance, they call it tree in bud appearance, because the alveoli are not seen too well. Then miliary pulmonary tuberculosis is rather serious as compared with other types of tuberculosis because it is a disseminated systemic disorder. And imaging detectable on radiographs only 6 weeks after hematogenous dissemination. In fact, several times on over-penetrated radiograph is taken, you may miss it. Fluoroscopy, forget it. You can't detect on fluoroscopy miliary tuberculosis. Several times, in my own experience, we have missed it. Radiograph showed beautifully the miliary pattern of the tuberculosis. And then HRCT can detect earlier than 6 weeks, generalized interstitial foci of pinpoint, approximately 3 millimeter sizes. Classical example of a miliary TB, note the chest film, there are multiple miliary pinpoint mottlings and diffusely scattered, multiple, they are discrete, millet size, that is 1 to 2 millimeters nodules. That's why often we miss in fluoroscopy as well as in radiography. And then ribs, the thoracic cage, the clavicles, the ribs, the sternum, the vertebrae. Of all these, the vertebrae are more common. And here the rib, lytic lesion in the rib, 8th rib, and then look at the soft tissue, localized pleural and parenchymal mass infiltrate, producing a huge density on CT in the cross-sectional view. Although in PA view it looks as if a patch of pneumonitis and pleural effusion. Another rib lesion, caseous necrosis, you could see central lucency, less dense than the rest of it. That is supposed to be typical of tuberculous abscess. It is displacing anteriorly the breast shadow. Actually, the patient thought it is a breast tumor. And then when we examined a cross-sectional view, definitely showed the tuberculosis of the rib with a soft tissue abscess and which displaces the breast anteriorly. Pulmonary tuberculosis can be divided into primary pulmonary tuberculosis, often seen in children, but now we see in adolescents and adults also. Post-primary pulmonary tuberculosis all infiltrates caseocavernous lesions, fibrocavernous lesions in both lungs, and of course miliary tuberculosis, which we talked about. Post-primary pulmonary tuberculosis, adolescence and adulthood. And what is the location? Apical and posterior segments of upper lobes. About 85% of the time, if you see the infiltrate in the apical segment in the upper lobes, think of tuberculosis. Somehow right is more involved than the left. Superior segments of lower lobes also is a common site. And then in the imaging, thick-walled irregular cavities is characteristic location in the apical segments and posterior segments of the upper lobe and superior segment of the lower lobes. Sometimes patchy or confluent, ill-defined areas of acinar consolidation. And hilar mediastinal lymphadenopathy may be present or may not be present. Sometimes from previous primary infection, you may see a now small calcific nodule in the hilar nodes and pleural thickening and effusion. In primary tuberculosis, pulmonary tuberculosis, actually it is in infants and children, location, middle lobe, lower lobes and anterior segment of upper lobes. These are the common sites for primary focus, but always these are associated with a regional lymphatic enlargement, lymph nodal enlargement. On imaging, one or more areas of homogeneous, well-defined airspace consolidation is perifocal exudate. Hilar or paratracheal lymphadenopathy, more right than left, and pleural effusion. Actually, tuberculosis may present only as pleural effusion. Later on, it may present as a primary tuberculosis or a post-primary pulmonary tuberculosis. But pleural effusion is common, particularly in young people, and there is no other cause except pleural effusion. Think of tuberculosis. The one on your left side, P and lateral views showing hilar adenopathy. All that patchy opacity is not hilar nodes plus perifocal exudate in the lung, producing a small pneumonitis picture. One on your right side, only hilar adenopathy, mostly on the right side, maybe a small infiltrate is noted in the right middle lobe. Sometimes you get a Brock syndrome. What is Brock syndrome? That is a caseous node in the right hilum erodes the bronchus and produces atelectasis and infiltration. That is what is called Brock syndrome. Primary TB in an adolescent, although it is common in childhood, occasionally we see in the adolescent also. And these are the two different patients showing same hilar adenopathy and perifocal infiltrates. And hilar adenopathy always does not mean tuberculosis. Here, for example, you see the right paratracheal enlargement, both hilar nodal enlargement. In the lateral view, it is anterior mediastinal enlargement. Although in tuberculosis, anterior mediastinal nodes or pretracheal nodes may enlarge, but it's more common in lymphoma. This is a case of lymphoma showing the huge nodes in the anterior mediastinum. And then post-primary tuberculosis, tuberculous cavity, and this is a chronic cavity with a fungus ball. Any chronic cavity can be invaded with a fungus such as aspergillosis. Thin-walled cavity in right upper lobe, as you see, with crescent sign, or what they call meniscus sign on a PA view of the chest. And then how do you know that it is not, for example, a ruptured hydatid cyst, or Rasmussen aneurysm, or an abscess, or a gangrene of the lung, or a carcinoma? How do you know? Well, first of all, there are peripheral infiltrates that shows it must be TB. Or there is history of being treated for TB. And then this fungus ball, if you take decubitus lateral views, erect views, supine views, it changes. That's how we know it is a ball. It looks like a ball. Actually, it is a debris, some blood, and fungi. All together forms a ball. You could see on CT nicely this ball. And then again, a cavity, but this patient has hemoptysis. You can see bronchiectatic changes and a big thick-walled cavity in the right upper zone. And then this is a 45-year-old male, complains of TB presented with massive hemoptysis. He knows it has been treated for tuberculosis. It was quiescent for some time, and then all of a sudden he came with hemoptysis. And HRCT shows bilateral cavitary lesions. Some of them are, of course, bronchiectatic cavities. And then the DSA showing aberrant common bronchial trunk arising from the right subclavian artery and going through the cavity, thus producing hemoptysis. And of course, this has been treated with embolization. Now, the heart. Heart is not exempt. Myocardium also is involved, but it's not easy to detect tuberculoma in the myocardium. But pericardium, commonly, pericardial effusion is common, and then it may result in constrictive pericarditis. It is chronic constrictive pericarditis with thick calcification. It should not be mistaken for a hydrated cyst or a myocardial infarct that has calcified, because characteristically it involves the inferior and anterior, curvilinear. So it is the pericardial thickening and calcification producing constrictive pericarditis. Now we come to the musculoskeletal tuberculosis. In the musculoskeleton, arthritis is more common than bone involvement. Tuberculous osteomyelitis you can get. Of course, tuberculous spondylitis, as I said earlier, 70% of the time it is more common in the axial skeleton, characteristically in the thoracolumbar junction. And you could see in the AP and lateral views of a child, in the AP view, you don't see the intervertebral spaces easily in the mid and lower thoracic spine, and there is a paravertebral soft tissue swelling. And particularly in children, a gibbous deformity is formed because of the collapse. Multiple vertebrae may be collapsed, that's why it forms a acute gibbous. And tuberculous spondylitis, it involves both children and adults. Location, upper lumbar and lower thoracic vertebrae. L1 is supposed to be most common, but we have seen L2, L3 also. And imaging, you see on demineralization or osteoporosis, resorption of vertebral end plates. It starts at the end plates. Contour irregularity of anterior and lateral aspects of the vertebral body. Absence of sclerosis is common as compared with, say, brucellosis, E. coli osteomyelitis or spondylitis due to fungal. And periostal reaction, of course, you don't see in these bones generally, because the periosteum is incorporated in the cortex. These are what they call cuboidal bone. For example, in tarsus, in corpus, in vertebral bodies, you don't easily get periostal reaction. Not that there is no periosteum, there is, but it's closely incorporated with the vertebral body, unlike it is loose in the long bones, particularly in children. Collapse of vertebral bodies, vertebral plana may be seen. Adults, gibbous deformity and anterior involvement is more common. Paraspinal infection, large cold abscess, that is characteristic of tuberculosis of the spine. In the paraspinal gutters or in the psoas, amorphous or teardrop shaped calcifications may be seen if it is chronic. Anterolateral scalloping of vertebral bodies. If there is a prevertebral abscess, it may scallop the anterior border, or the abscess may spread posteriorly, compressing of the spinal cord, producing paraplegia. Pott's spine is the tuberculosis of the spine with paraplegia. Potts has described it a long time ago. Multiple destructive vertebral lesions with paraspinal soft tissue, and incidentally noted, particularly on the left side upper picture, a calcified putty kidney. We'll come to it when we deal with genitourinary tuberculosis. MRI of the part spine, of course, in a classical case, plain radiographs will give you a clue that it is tuberculosis spine. But how much of paravertebral soft tissue swelling is there? If it is in the thorax, you can see the paravertebral soft tissue. If in the abdomen, you don't see easily, although the psoas may bulge and all that. In those cases, you need a MRI. Not only that, MRI helps in noting the multiplicity of the vertebral involvement, which are undetected or not significant clinically, but it may involve vertebral bodies. Another thing is, this post-vertebral soft tissue swelling or the abscess may go posteriorly and compress upon the spinal cord, producing neurological symptoms. That's why MRI is very important in case of tuberculosis of the spine. You may have a radioisotope scan, but it only shows some sensitivity, but it doesn't really give us the specificity, what exactly is going on. For example, old fractures may be heart. That doesn't mean it's all